Great. Welcome, everybody, to this fifth one in our series of EUPFF webinars on, in this case, pulmonary fibrosis cough, what causes it, and what can we do about it. My name's Steve Jones. I'm a board member of EUPFF, and I've been asked to moderate the session tonight. I'm really pleased we've got some excellent speakers tonight. First and foremost, we've got an old friend of EUPFF, Dr. Phil Molyneaux from the Royal Brompton Hospital in London, and also a professor at Imperial College London. Phil is really one of the top researchers on pulmonary fibrosis in Europe, and we're really pleased that recently he's turned his attention to PF cough, which, as we know, for many of us, when I had IPF before my transplant, really suffered with a debilitating and very heavy cough for many years. And I know many other people listening to this program, listening tonight, will be in the same position. So we're really glad to hear Phil. As usual, we're recording this session, and it will be available on our website because not everybody can always come to the meetings when they're timed. So welcome, Phil. We're also got with me Andy Straw. Now, Andy and I are old friends. We met 4 days ago, and I had a long conversation with Andy, who's been diagnosed with pulmonary fibrosis, particularly about cough. And he was so eloquent that I thought we'd invite him to come along and give a patient's perspective on cough. By inviting you in, Andy, we've put John, my colleague and the president of EUPFF. He won't do the introduction, but he'll come in after Phil has finished speaking and give his reflections as well, as a patient currently living with PF cough. And we'll be opening up the discussion for everybody in the room. Now, after Phil has spoken, I think, Phil, for about 25 minutes, you said, I think. Great. And just a couple of housekeeping points to start with. Put any questions you'd like to raise, put them in the Q&A, not in the chat. You see the Q&A button at the bottom of the screen if you're on Microsoft. Not sure where it is with Apple, but it's questions into the Q&A. Please make them as succinct, as short and specific as possible, and I'll be fielding those and passing them on to Phil. You can put your name, but we won't read your name out, but it might be helpful later if it's a particular question. And then the second point, sorry, can you put, Alba, could you switch on the slides, the first one? Take us forward. Well, I can do that, can I? No. And the next one, please. Yep. So here are your speakers for tonight, and the next one. Yeah, so we have the Q&A, this says chat. We don't want you to put it in chat, put it in this one, the Q&A. And then the next slide, please. And our special feature is we've got Zoom translation. So if you want to translate, go down to the bottom and you'll find it. You may have to push the little button with 3 things on. You'll get the translate button, and you can say which language you want to listen in. So you can have translation in English, my speaking language, or you can go into any one of the languages. I'm not sure if you're seeing my screen now. On the other side, there's a whole long list of all the questions you can do. So go into captions and translation, and then you click my speaking language and choose from the drawdown menu which you want, from Afrikaans to Malay to Estonian. All languages are available, and then you'll get translation into text on your screen. So I hope that's all clear. Now, with no further ado, Phil, I'd like to hand over to you to give us the main talking tonight, please.
Thanks, Steve, and thanks for the invite to talk about pulmonary fibrosis and cough. And I was challenged with talking about what causes it and what can we do about it. So I've got a number of disclosures which aren't...
So Phil, I beg your pardon, Phil. Sorry, Andy, we'll come back to you afterwards at the end of the talk, yeah?
Do you want to go back and start with Andy?
Andy, would you like to start? Sorry for this.
Yeah, no, I don't mind. I don't mind. I'll come in whenever you like.
Come in at the end after the talk. You go first, Phil.
Okay. All right. Well, we'll take 2 and start again. For anyone watching it online, hopefully they edited it and it looked a bit smoother with an introduction. But if not, we'll blame Steve. So I've been challenged with talked about pulmonary fibrosis cough, what causes it and what can we do about it. I've got a number of disclosures which are not relevant or impacted in anything way I'm going to say today. I'm going to start with a patient, and that patient is Mr. X. And he's a 67-year-old man. He's an ex-smoker, and he has high blood pressure. And he presented with 18 months of cough, and the cough was non-productive. It was irritative. Got worse when he tried to exert himself, and he predominantly noticed it in daytime, and it didn't really interfere with his sleep. Now, Mr. X was diagnosed with idiopathic pulmonary fibrosis, and the cough was deemed associated with IPF. Now, why is cough a problem? Well, when we think about cough, we have to think about the effects it can have. Most people initially go to the blue section, the physical section. It causes chest pain, sore throat, can in fact impact upon your sleep. People can cough so much they vomit. People can have urinary incontinence, stress incontinence because cough gets so bad. So that's probably the first thing that people think about. But there's another whole dimension to cough. It causes social isolation. It can impact relationships. It can disrupt your daily activity, and it can impact upon your work. After COVID, everyone's very conscious of cough, and certainly, you know, in the last few years, more and more people are conscious of people coughing around them, and that can be very isolating. It can make you not want to go out, the theatre, the cinema, the tube, the fear of people staring at you and looking at you at work. It can be really isolating for patients. That then draws in the psychological domain that cough brings. It's shame, anxiety, and ultimately and often depression. So cough doesn't just cause physical symptoms, it causes social problems and psychological impacts. And cough's a problem for patients with IPF. And in this, I'll talk predominantly about IPF, but I think probably the data we've generated so far says that most of the things I'm going to say to you about IPF are true for other forms of PF as well. 85% of patients with IPF report a cough. Now, that can be from occasional cough to the most severe cough, but 85% of patients, when asked, will report a cough. When you look on the right of the screen here, we look at, this is cough counting. So when you count somebody's, how many times they cough, the average person will cough once a day, okay? Patients with asthma cough a few more times a day, but patients with IPF cough the same as patients with what we call refractory chronic cough. So these are patients where they've got cough for no known reason. And that's kind of the benchmark when we think about cough. So patients with pulmonary fibrosis and IPF here, coughing the same as patients with refractory chronic cough. And that's 10 times an hour. Cough's a problem in the day for patients with IPF. And you see here the cough count on the left in the day and on the right at night. And it drops dramatically. Now, we don't really understand why this is. And in other diseases where cough's a problem, and certainly refractory chronic cough, we don't see this daytime predominance. But 95% of the coughs we record for patients with pulmonary fibrosis are in the day. And that's a common feature that we hear time and time again. And that leads us, it gives us a few clues about how we can treat it and things and things that may be causing it. It's a problem that remains stable over time. Now, what do I mean by this? I mean, historically, we've often thought of cough as something that comes on and gets worse as the disease changes. But actually, for the majority of people, and we look on the left here with using the Leicester cough questionnaire, so how bad do you think your cough is? If you group people into big groups, the green group are mild at the bottom, and those patients at the time of diagnosis who have a mild cough, the majority of them continue with a mild cough for the period of the disease. At the top, you've got patients with a really bad cough when they start. And some of them might drop down to moderate cough, but none of them drop down to mild. So people with IPF have a cough, and that cough can be present at the start of their disease journey. So it can be the first symptom they present with, or it can be a symptom that they have when they're diagnosed. And that's important for us to think about because, you know, your journey as a patient can be a number of years. Historically, we've thought of cough as something that comes on later on in the journey and therefore not worthy of focusing on. But actually, the data that we're seeing now suggests that cough's a problem at the time of diagnosis and should be something we're focusing on. Cough impacts quality of life. I've told you that with the first figure, but the data backs that up. And we look here at a cough VAS. So how bad is your cough out of 100 in this case? And 30 is a reasonably good cutoff for people with cough or no cough. If you put down 4 or 5, you've probably not got a massive problem with cough. If you put down 100, you definitely have. And 30 works as a nice cutoff. And when we look at patients with a cough above 30, so they're the ones on the right of both of these figures, they have worse quality of life. So the LCQ, the lower you score, the worse it is. And the LIPF, another questionnaire we use to look at quality of life, the worse your quality of life is. So patients with significant cough and pulmonary fibrosis have a worse quality of life. Now, the million-dollar question is what causes cough and pulmonary fibrosis? I've got a really complicated figure on the left of the screen. Central nervous system, the brain, the nerves coming down. All of those things have been implicated in cough, and there's a cough reflex. So there are nerves that come down from the brain that help trigger cough, and sometimes that can be a problem. There are nerves within the lungs that can potentially be irritated and cause a problem, and there's lots of other things and receptors within the lungs that could potentially be a problem. We don't know, is the honest answer, what causes cough. Some theories are excess mucus. For some people, it may be reflux or spillage of the stomach contents over into the lungs. Could be, as I said, nerves. So the nerves are a problem. The lungs in pulmonary fibrosis are abnormal. You saw that CT scan at the beginning. There's scarring, they're stiffer, they don't work as normally, and that causes problems when people breathe in, and can often, one concept is that there's a stretch problem, or there's pressure changes which within the lung and the chest wall and the stomach, which cause these coughing problems. But the true answer is we don't know, and probably the cause of cough in everybody isn't going to be the same. There's going to be groups of people where mucus is a problem. There's groups of people where there's cough reflex, where the mechanical stretch is an issue. So I don't think there's going to be one bingo, that's the exact cause of cough for pulmonary fibrosis. But that doesn't mean that we don't know what we can do and how to treat it. I mean, I say, is it as simple as that? Is there just one cause of cough? Well, no, there's not. And this diagram looks quite complex, but essentially within pulmonary fibrosis, so we've got IPF, the diagnosis at the top, a lot of people have cough, but a lot of people also have reflux, which is on the left, GERD for the Americans watching. And reflux is associated with cough, but reflux is also associated with IPF. So do you have reflux that causes IPF and causes cough? Do you have IPF that causes reflux and that causes cough? And there's also the association we see with obstructive sleep apnea. So some people have problems with their breathing overnight, low oxygen levels overnight. That's associated with cough. That's associated with IPF. But likewise, they're all interrelated. So although I've told you that we don't know one specific cause for pulmonary fibrosis cough, there's also a lot of comorbidities or other problems that patients have that are interrelated. So overall, my summary of this is that we don't know what the cause of cough is, and it's pretty complex. But what does that mean for patients? Well, this is Mr. X. What happened to Mr. X? Well, Mr. X was given 6 months of inhalers. He was given 6 months, and inhalers treat airway inflammation, often used in asthma. Didn't help. He was then given 6 months of omeprazole, and omeprazole treats acid reflux. And again, acid reflux often associated with cough. That didn't help. He was then given 3 months of mucodine, carbamazepine, to loosen up the secretions in the mucus, and that didn't help. And after that, he was then given some codeine linked this. Codeine acts as a cough suppressant, and it can be bought over the counter. That helped a little bit. And once they realized that helped, they then used PRN oromorph, so a stronger opiate to help suppress the cough, but hadn't taken the cough away. And that was 18 months. Now, you can't give everybody all the different medications at the same time. So if you'd given everything at the same time, you know, how do you know it worked? And that's the problem with cough, and the treatment of cough is often sequential. And historically, we've been told to try and trial treatments. So, you know, inhaler, PPI, the omeprazole, mucodyne, codeine, Linctus. But that, for a patient with refractory chronic cough and no pulmonary fibrosis, it might be okay to work through these things in sequential manners. But in a patient with pulmonary fibrosis who's got a limited life expectancy, using 18 months of that to try sequential therapies means that for 18 months, that patient has had symptoms. So what do we try and do in clinic? Well, this is taken from a guideline, so it's a nice flow chart. The first thing we do is treat the underlying interstitial lung disease. Now, for pulmonary fibrosis, for idiopathic pulmonary fibrosis, that's obviously antifibrotic drugs, but for other interstitial lung diseases, there are immunosuppressive drugs that may be used, and often treating with immunosuppression and dampening down inflammation can help in some cases. So we will maximize the treatment we have for the underlying interstitial lung disease. And we'll then look for common things that cause cough in everybody. So just because you've got pulmonary fibrosis doesn't mean you're special. If you're still smoking, then we'll tell you to stop smoking, because smoking causes cough. Okay. If you're on some drugs which cause cough, like ACE inhibitors, often used for high blood pressure, then we'll tell you to stop them. At that point, we'll start to ask more questions. Is there a history of asthma? If there is, then we can do some more tests to look if asthma-like symptoms are causing cough. We can look for reflux. We can treat reflux. We can look at problems with larynx and the upper airway, and we may need to go to ENT specialists or gastroenterology specialists. But essentially, the doctor looking after you is asking questions and doing tests to try and find the most likely cause, because if there is a likely cause, that can be intervened on. And if you can intervene or remove something, then that's probably one of the best ways of helping improving cough. If after all that the cough remains, then we have to try and think about treatment for presumed pulmonary fibrosis cough. And we've got this nice steps management strategy that we put in the upcoming EU monograph. And it starts with stopping smoking, a medication that could cause cough. And then we think about treatable traits. So that's acid reflux, obstructive airways disease. Once we've ticked off the common things, we think about speech therapists. So speech therapists are very good. They're very few and far between. Often physiotherapists can also help with managing cough. They can look at cough suppression techniques. They can look at breathing techniques that will help. And they're often very successful. A glass of water is there for hydration. That is very important. And patients with pulmonary fibrosis and cough should carry water with them and sip water all the time. You know, there's a reason they put water on a lectern for talking, because when your mouth gets dry, your throat gets dry, and your cough gets worse. So some simple interventions: physiotherapy, speech language therapy. We then move on to pharmacological treatments, and we're going to cover those in a minute, but predominantly related to opiates and cough suppression. After that, we're thinking about working with cough specialists, considering clinical trials, and working through this as a stepwise approach. We're trying to really identify easy wins. So if someone says, you know, I'm still smoking, it's an easy win, stop smoking and your cough will get better. Okay. If someone's on a drug that's associated with cough, we can stop it. The further we get along this pathway, the more difficult it is. So we try and get the easy wins to start with. So treatment options. Well, this is an overview of the last few years of studies of cough, of drugs for cough with pulmonary fibrosis. And we start down with sodium cromoglycate, and that looked positive. Study done by Professor Biring back in 2017. And you'll see in some examples of cough studies, but generally in a clinical trial, we start with a small study with a few patients, make sure the drug looks safe, make sure it looks like it's working, and then we go to a bigger study to make sure those findings were correct. So the first study was positive and it looked good, and it looked like it reduced the cough by around 30%. So that led on to the next study, the scenic study. Unfortunately, a lot of patients dropped out. It was around the time of COVID, but all in, the study was negative. So that it didn't look like a good treatment for cough in patients with PF. On the bottom, we have gefapixant. And gefapixant is a drug that targets some of the nerves and pathways involved in cough. It's used in refractory chronic cough, but it wasn't known whether it would work in patients with pulmonary fibrosis and cough. This study was plagued with problems, and I put down their randomization error, and there were many issues with this study, but ultimately it was negative, and it's kind of put a nail in that one. There are other drugs coming later on that are related to gefapixant that may well have potential in PF, but at the moment these drugs are not looking or have not been shown to be positive in any clinical trials. We then come up the arrow a little bit more on the bottom here to the CANAL study, so then to nalbuphine ER. We're going to cover that one, the PACIFY study, and the CORAL study, all three of those in a bit more detail. At the top of the page, we've got IPF Comfort, which was a study run again by Professor Birring at King's, and we've got another Boehringer study with a compound name there that was ongoing at the time I put these slides together. I'm going to focus today on the CANAL, the PACIFY, and the CORAL study, and give you some updates of what's been going on. So I'll start with PACIFY, and this is a study we ran at the Brompton and Imperial, and it was a study of morphine sulfate. Morphine is an opioid, and it suppresses cough. And we looked at giving patients 5 milligrams twice a day. Now, I'll show you the study design because these are the earlier studies I talked about. And the best way to check whether it works is to give patients a drug or a placebo. Now, you can do that in a small number of patients if everybody has drug and placebo in order. So you go into a study and you have part A, and the top group in part A got the drug. And then when they went to part B, they crossed down onto the bottom and got the placebo. So this way, everybody is their own control. One of the problems in cough studies is that when you're in a clinical trial, you get much more attention. You get given a drug and you get told, I think this drug helps cough. So people think that the cough gets better. That's the placebo effect. So in doing it in this design, everybody's their own control. And some people get the drug first and some people get the placebo first. So you should dilute down the placebo effect. Now, we took patients who had a cough, who had pulmonary fibrosis and had a cough over 8 weeks. We used this VAS cutoff of 30. So how bad you cough out of 10, over 3, or at 30 out of 100. And we said you had just to have had lung function that was recordable. And we looked at cough counts. So we put cough recorder on patients, recorded how often they coughed, and then we gave them the drug, and we recorded how long they what they coughed for at the end of the study. 44 patients came in, and the majority of them went through the study. So as you see, we had 14 days of morphine, we had 7 days off, and then we had 14 days of morphine or placebo again. So it was a relatively short study. And on the left here is the morphine in blue, and morphine reduced cough by 40%. On the right, we see the placebo in orange. There's only a quite small placebo effect, but there was an effect of the placebo. But morphine had a much more stark and obvious effect. When you reduce cough in these patients, so we'd obviously counted cough, but the question is then what do patients notice? So we asked them what they thought their cough was like at the beginning and the end. And at the beginning, patients on average said their cough was 60% bad. And on the end, they said it was 45% bad. So patients reported that their cough felt better. They also felt better themselves because their LCQ score went up from 13 to 15. So overall, patients on the morphine, their cough went down, they felt their cough went down, and they felt the quality of life went up. But it's morphine. Morphine is a drug which has some significant side effects. It also has many connotations with end-of-life care and an addiction that is a problem that's been highlighted recently with the opioid epidemic in America. So although it is a drug that works for cough, it does come with a number of concerns about its use. So nalbuphine is a drug which works on the opioid receptors, but doesn't, the way its pharmacology works means it doesn't cause the dependence or the respiratory depression. So it's kind of like has all the good bits of the morphine, but not all of the bad bits. And the study here is their first smaller study, and it's a crossover study, exactly the same design. It's not rocket science doing cough studies, early ones anyway. You put people in placebo and then drug, placebo and drug, and use each person as their own control. Here we did 22 days of each compound, and patients built up a dose rather than starting on one dose and going all the way through it. That study was positive, and it showed a 50% placebo-adjusted change. So you can say, you can look at all things, so the numbers change because you can say there was a 70% reduction, but actually what you have to do is look at the placebo effect. And in this study, the placebo effect was about 20%. So if you were just on a sugar tablet, your cough got better by 20%. But if you were on the drug, your cough got better by 75%. So, it was a significant reduction, but again, in small numbers. So that led on to the CORAL study, which is a study that has just finished, and we presented the data at CHEST a few weeks ago in Chicago. And this was a larger study looking at 3 doses compared to placebo. So there was no crossover now. Patients went into one arm or the other, and they stayed there. And the patients were in the study for 6 weeks. They looked at cough count at baseline and then cough count at the end. So again, the primary endpoint was counting the number of coughs and looking how it changes. The secondary outcomes, though, were looking at how patients felt their cough was, how severe it was, how often they coughed, and what their quality of life was. So the headline data was looking for cough count dropping, but the secondary endpoint was all about how do the patients feel. And the great news is that the cough frequency dropped on nalbuphine. So we see here in the grey, there was a 17% placebo effect. So just being in the study made patients' cough count go down. But there's 3 doses of the drug, 27, 54, and 108. And you see a nice dose reduction on each of the higher doses. So as the dose goes up, the cough count goes down. Looking at, almost all 3 doses are achieving a 50% reduction in cough counts over 24 hours. And that's impressive, but it's even more impressive when you look at this cough improvement happens after just 2 weeks. And all 3 of the doses improved cough count after 2 weeks, and the cough count stayed down for the duration of the study compared to the placebo in the grey line there. So there's a clear and obvious difference. People also felt better on this, and they also felt their cough was better. So on the left here is the cough numerical rating scale, and that says how bad is your cough in the last 24 hours from 0 to 10. So 10 is the worst cough possible. And then we looked at change from the beginning to the end, and actually patients on the 54 and 108, the 2 highest doses, noticing significant changes in their cough. So, going down by 3 points on average. So that's, taking you down from 7, from 10 to 7, but you could be taking it down from 5 to 2. So it's a significant improvement. And when patients were asked how they felt using the Leicester Cough Questionnaire, again, the 2 highest doses had a marked and significant improvement in their quality of life. So I'd like to conclude by saying cough is a significant issue for patients with IPF and other pulmonary fibrosis. Not all causes are linked to pulmonary fibrosis, and a systematic approach can work for some people. There are new therapies in the pipeline, And future clinical trials with longer treatment durations are required to examine the durability of these effects. And one of the outstanding questions is, does treatment alter the disease trajectory? And I think that will be important to answer as we take these drugs into later phase studies. With that, I'd like to say thank you, and I'm happy to answer any questions.
Bill, that was absolutely great. Thank you so much for bringing us up to date on that. I've been a bit closed off for this last year or so, but to see the progress now is really very optimistic for patients. I wish that they'd been available when I lived with PF drug 10 years ago. But we'll come to questions in a moment. First, Andy, would you like to give us your perspective of a patient living with the disease? And before you do, just everybody remember, questions into the Q&A, and we'll ask Phil and Andy questions afterwards. Over to you, Andy.
Okay, well, thank you very much, Steve, for inviting me onto the panel. It's really, really nice to speak to you all. And it's nice to know that I'm not alone, and patients aren't alone in this debilitating episodes that we have. At the moment, as you can see, I'm presenting as a normal person with no cough, but send me up the steps to my road and is a different story. It's hard work. I tend to cough when on exertion. Every time I do anything exertion wise, I cough quite a lot. So much so that sometimes I feel the need to be sick, and it's often I am sick. But it's always productive. I'm really trying to get a load of mucus off my lungs, and that's essentially what I'm doing. And it's thick, gloopy, and it's white, and it's foamy, and it's hard work to shift. But once it's out, you feel a little bit better. But as you continue on your exertion route or whatever you're doing that day, it builds up again, and then you find yourself having to stop and go through the process yet again. In the evenings, it's not so bad at all because again, I'm not under exertion. I'm sitting down, I'm resting like I am now. I do have the odd coughing fit sometimes, but my doctor prescribed me gabapentin, which has really helped with the cough. I still get the cough, but the gabapentin has really helped. And he started me on a lower dose to start off with, but I didn't feel any help with that. But then he upped the dose to what I am on today, which is 300 milligrams 3 times a day, and it significantly helped with my cough. I still get the cough and I still struggle with it, but it's reduced it quite a lot. So I'm really pleased with the gabapentin. Other than that, it's like I say, it is hard work, and as Phil mentioned earlier in his presentation about the social aspect behind it, I do find it quite worrying when people are staring at you in the street, thinking you're going to pass something on to them. And I've said to Steve before, I feel like getting a 9-foot illuminated sign over my head saying, "Don't worry, you can't catch what I've got," to put people's minds at rest. But you've got that in the back of your mind all the time, people staring at you and think, oh, and you try and suppress the cough. And then that's the worst thing to do. It's not good for you. So, but it comes out anyway. You can't suppress it no matter how much you try. But yeah, it's good. And the gabapentin has really helped. And I was surprised when my doctor prescribed it to me because it looked in the notes in the drug in the actual patient notes. It says it's for people with epilepsy and people who have seizures, and I don't suffer with either of those. But he did state that it in some people it does reduce the coughing, and I must be one of those some people. So I'm forever grateful for that.
Great. Thank you very much indeed, Andy. What about psychological impacts? Did you find yourself that you started becoming more stay at home, less willing to socialize and things like that, or?
I don't think so with me. I think what it happened with me, Steve, is I'm trying to be as sociable as I possibly can to still continue to do most things that I already did before. I remember I mentioned to you I play lawn bowls in the summer months, and I do cough a lot whilst playing lawn bowls, because when you're walking up and down the green, it's exertion, and I do cough a lot. But the people I play with understands my condition, and the kind of are used to it. But when I play other people, they sometimes offer me a sweet, and they sometimes offer me a drink of water and things like that. So there is an act of kindness involved with it.
Mm.
But essentially, but for people, just general people on the street that I don't know, they just look at me with daggers and thinking I've got COVID or something.
There's a stigma associated with it, isn't there? Yeah. I remember I used to go in, sometimes going out for a meal with friends. I would go into the loo and I just cough it out, for as long as it took, and then go back to the table rather than coughing at the table. It's just the way you change your life to try and pretend you haven't got a cough. I was still working and I had one of those speakerphones, and I had my finger constantly on the mute button, so that as soon as I felt the cough coming, I would mute it so the client I was speaking to didn't hear me coughing. But you try to do your best, don't you? Thank you very much, Andy. That was great. Phil, we've got, you might want to reflect a little bit on what Andy said. But I've got a question that's come up now is about, the morphine and the risk of addiction. Is the dose so small that there's no risk of addiction, or is that something that you have to be concerned about? So,
as I said, morphine comes with a number of connotations, and one of them is addiction. So I think it's important to think about why someone would be being prescribed this. So you're being prescribed it by a clinician who has made a decision that you have a symptom that they can help with. And if you're therefore prescribed a drug, then you're not. I struggle to find the right words. So there's a difference between addiction and dependence. So if you take morphine regularly, you can't, and take it for a long time, you can't just come off it, because there is a risk that your body was used to getting morphine. So yes, if you take morphine regularly, your body can get used to it. And that's why sometimes we need to go up on the dose. So there is an association with dependence, but if it's helping your cough, why would you want to come off it, is my point. So if you're given a drug to try and it works and you don't get side effects and you tolerate it, you don't need to come off it. So are you then addicted to it? No, you're taking a drug which is helping you, and you should carry on taking it for as long as you need. So I understand, I've seen the Netflix programs. These are people that were using drugs inappropriately. We're using drugs outside of prescriptions. So I think it's important to differentiate the addiction and dependence. Yes, you can become dependent on it, and there is a risk of withdrawal. But if it's helping your symptoms, which it appears to do, then that's a conversation to have.
That's right. Another question, Scott. We've got 3 or 4 questions from our colleague in Greece, which is wonderful. And she asked whether antifibrotic medications, nintedanib, pirfenidone, affect cough, make it worse, make it better. Is there any evidence one way or the other?
So it definitely doesn't make it worse. There is some evidence that it may make it better. I think that evidence is relatively weak, and I would certainly never promise anybody that it was going to help make their cough better. As you see, in cough studies, there is a placebo effect. So by getting therapy of any kind, it can make people feel better about the disease, more positive about the disease, because they're actively doing something, and that can make people feel better and therefore their cough feel better. But I don't think we have any hard evidence, the very small numbers of patients where people have reported an improvement.
I mean, are there any other triggers associated? I mean, I know since I had my transplant, I don't know whether it's what affected me before, but I have nasal drip, postnasal drip. And that's a constant cough for me, which isn't low down, it's just up here,
And that's the thing. That's why I say, you might have pulmonary fibrosis, but not everything that you get is caused by your pulmonary fibrosis. If your toe hurts, it's not to do with your pulmonary fibrosis. So when we work through systematically, we're looking, and I included inflammatory disease. I focused on asthma, but yes, you're right, postnasal drip, rhinosinusitis. So they're things that when you speak to your clinician or your nurses about, they will get. Apologies if you heard interloper in the background.
They want their dad. He's 20 minutes to them. Don't worry, Phil, carry on. Yeah.
So it's all right. That's why we look to exclude and identify common things. So if you tell us that you're forever sniffing, or your nose is running, or you feel there's something dripping down the back of your throat, then your doctor or nurse will prescribe a nasal spray as a trial. But if we go through this and I say to you, Steve, have you got any of these symptoms? And you say no, we shouldn't be putting you, Steve, with none of those symptoms suggestive of postnasal drip on a nasal spray for 3 months, because it's not going to work. It's going to get rid of you out of my clinic for 3 months, and then you'll come back, and then I can give you a PPI for another 6 months. But for treating cough is about treating the things we can identify and not just giving empirical treatment.
I mean, when I had it before I had IPF for 8 years, I was diagnosed initially because I had a tickly cough, a dry, persistent kind of cough. But by the end, certainly within 3 years of me having a transplant, so I was getting quite advanced. It was a very heavy mucousy cough. It was different. It was a different cough to the one I had to start with. So in a way, maybe the things that caused the first one were still there later, but they were superseded by the amount of mucus I was producing.
And people are different. Some people have no mucus. Some people, I hear quite often, like patients like Andy, where I'll often hear that they'll, a common thing is that in the morning the mucus is there, and patients will go in the shower and cough and clear it up, and then they feel better for the day. And that's where the whole trial of things like mucodine comes in to thin down the secretions. But we don't have a way of identifying who would respond to mucodine, who would respond to nasal spray, who would respond to steroids. So it's really tough.
I mean, the cough is in a way almost worse than the breathlessness at times. It's so bad. A couple of questions, very interesting ones here, about what simple things can people do at home to help calm cough when they get it, like breathing techniques, posture, avoiding triggers. And linked to that, if I'm a carer, what can I do to help my patient when they're having a fit with coughing? When it gets so bad that you're having to get it out and you're becoming very, very breathless at the same time.
So it's really difficult. That's the first thing to acknowledge, that it's not something that I can click my fingers and make better. I think there are ways that you can help control your cough. I think APF have got quite a nice page on it with some breathing techniques, and certainly some of the in through the nose, out through the
APF,
mouth.
everybody, is the Action for Pulmonary Fibrosis UK charity.
The UK charity have got some nice breathing techniques on there, and that's why we talk about physiotherapy and speech and language. So some of the things they can teach you are breathing techniques. You can sipping water, keeping well hydrated. Some people like to use throat sweets. Some people, it's a mental thing about actually sitting down, calming down, and just breaking that cycle and knowing that the coughing will stop. Other people will use medication. You mentioned breathlessness. Coughing fits can induce breathlessness, and for that, you can focus on medications like lorazepam or other drugs which can help take down anxiety, because it's completely normal to feel anxious when you cough and you can't get your breath. It's completely normal, and there are medications that can help with that.
I found that if you're trying to speak, often just putting oxygen on. If you're on ambulatory, just putting a very light, half a litre or a litre of oxygen, so smoothed it enough to calm it to make it possible.
It's difficult, Steve, because some people will tell me that their cough is worse when they exert themselves, and there are some people whose cough is driven by low oxygen levels, and you walk them along a corridor, their oxygen levels drop and they cough, and you give them oxygen and the cough goes away. So for some people, oxygen can be a help. Certainly, if there's patients who only have exertional cough, I will often make sure they've definitely had a 6-minute walk test to look for whether they have an oxygen requirement, because sometimes it can be the only sign.
I mean, is there any link between worsening of cough and acute exacerbation, or even more sadly passing away?
The data is very difficult. I think overwhelmingly that there is some change in cough over time, but it's not really significant. And by that, I mean, it's, very small numbers. When people, towards the end of life, cough can get worse in the final stages of the disease. But that's kind of separate to the main trajectory of the disease, and everything we say that cough's a problem for some patients from the start. And if you see a patient with a cough at day 1, they will still have a cough at year 3. So that's what my point was earlier. We need to get on and treat it as early as we identify it.
Possibly can. Somebody's raised a question of a trial that was done for patented RX-N115 non-steroidal nasal spray drug, which seemed to have had a positive impact. Is that something you're...
Well, look, you gave me 25 minutes to talk.
I know, yeah. Would you have talked about that one?
I picked my own study and then the most recent one. So, yeah, as always, the caveat for this is apologies if I didn't talk about something that you've been particularly interested in. I think that was an interesting study. It was relatively small numbers, but it was positive. I think, for me, it still needs a little bit more exploring in larger patient numbers. And over a longer period of time. As I said, the study we've seen with nalbuphine, it was only 6 weeks, and ultimately we want to see what these drugs are going to do for patients over a year.
Yeah, and a question from another one here about the whole process of walking and moving around. Does it loosen it up so that it becomes worse? Does it help? I mean, is it, you probably can't, different people,
everyone's different. Look, some people tell me they use steam inhalators and it works, and that some people tell me they use them and it made it worse. Some people like change from hot to cold, cold to hot. It gets better on holiday, it gets worse on holiday. I've heard it all. I think overwhelmingly, if you feel like there is something in there that coming out, then often that's where we will use drugs to thin up your secretions. But at a point, this sensation that stuff needs to come out, it doesn't actually need to come out, and it does come out when you're asleep. Your lungs move this out and move it around. So sometimes actually making people try and cough for more just causes more irritation and more distress. And that's where the drugs that are centrally acting, like morphine and nalbuphine, suppress everything down. And it's important to realize that your lungs do clear this out while you're asleep, even if you don't think that.
God, I wish I'd known that. I always take these opportunities to advertise electric bikes, and I bought an e-bike before when I was in the last year of having IPF, and I did that because it really made you breathe with your lungs. And I had a particular place where I would just empty my lungs at the side of the road. It was horrible to think about, but it made me feel better. So for me, it worked, but for the next person, it might not. Yeah, as you were saying. Yeah. Andy, would you like to come in with any question for Phil or comment on what you've heard?
Yeah, the oxygen thing, the lack of oxygen, I never really considered that until only recently, because I decided to test myself with an oximeter when I walked home from work, because I walk up a fairly steep incline. And whilst doing so, my oxygen level went down to like 68%. And I never got any dizziness with it, which you kind of expect when your oxygen levels are low. So I spoke to my doctor just recently, and I mentioned it to him, and he said that tells me you have been on low oxygen for quite a long time, and your body has gotten used to it. So I'm wondering now if my cough, which started around 3 years ago, is due to the actual lack of oxygen when I'm actually walking around. I have got a walking test on Friday to see if I go on ambulatory oxygen, and I think I probably will be, judging by my recent SPO tests on my oximeter.
Yeah, be nice to come back to us with your continuing experience, Andy, and we'll do an article on it, actually, or a small video.
It is, and it would be interesting to see how you find it, because certainly, people where cough is triggered by hypoxia, and often, again, a common theme I will get is, I get up in the morning and my cough is really bad. People will use oxygen in bed to pre-oxygenate before they get out of bed, before they go to shower, before they go to put on the clothes. It can often help.
Great, yeah. John, here, unusual for you, you've been sitting quietly. Would you like to give your perspectives and your reflections on what you've heard? Because John, if I introduce, is an IPF patient and the current president of the European Pulmonary Fibrosis Foundation. And all the time I've known you, you've suffered with cough. In fact, you've given yourself a nickname of Sir Cough-a-lot.
Yes.
So over to you, Sir Cough-a-lot.
Thank you. I even made a crest. I think I've shown it to you as well. So if I ever going to be knighted, and the chance is slim, I will take the noble name Sir Cough-a-lot, because that has been, Andy, with your story, you could be my brother. It's what you're telling me, it's quite recognizable. What I think is that no matter how much science is working, you need to learn how to live coughing. I know that I had to relearn how to live in my body coughing, because I've been doing it all. I've been coughing so hard. I've been losing consciousness for several times. I've broken ribs. I've done it all. So basically, what I also picked up on, Phil, it was a very interesting talk. Thank you. Was the mechanical stretch. In IPF patients, you can also have something called traction bronchiectasis. That's where the bronchi tree is pulled apart by the fibrosis. Can that also have an impact regarding the sensation to cough?
Yeah, I mean, good question. I'll reverse it slightly, because I often get patients talk to me about traction bronchiectasis, because bronchiectasis is like cystic fibrosis and bronchiectasis, where the airways are bigger. And in those diseases, patients have a lot more mucus and infections because their airways are big and they're not as good at clearing it out. Now, in pulmonary fibrosis, it's slightly different, because you get bigger airways because the tissue pulls the airways apart, so they're kind of splintered. So actually, we don't see it acting as in a similar way to true bronchiectasis. So we don't generally see the same volumes of sputum. And although everybody here may have a productive cough or talks about productive cough, these patients with bronchiectasis are coughing up big cupfuls of mucus every day, which is very rare in IPF, even if you've got a productive cough. So there's something different about it, and we don't really understand it. But the architectural destruction could well be one of the triggers for cough.
Thank you. What I've learned, or what I do, is that I've made a couple of rules for myself. I'm never late for anything, because stress, and you said it good, it doesn't have to be. Exertion is for me something where you're really pushing it. It doesn't have to be. When I get up after this, I will start cough. I'm sitting relaxed now. I've been relaxed for a long time. And then I can sit close to for hours just coughing a little bit. But as soon as I get back up again, I start coughing. So basically, I learned myself, my walking pace is just below coughing standard. So I learned tricks and tricks not to initiate my cough.
Interesting, yeah. And also, as you say, by not rushing, you don't get that adrenaline rush that makes you worried and nervous, which brings on breathlessness for me, but also brings on cough. Yeah. So, Phil, any reflections?
Yeah, I mean, again, it comes down to what works for you, and it becomes very difficult when I get asked what should I do. I don't know. Do it systematically. Do what makes sense to you. If someone tells you something and it sounds really stupid, then probably don't do it. There's questions about, should I use this herbal treatment, any other treatments? Again, if it sounds logical to you, it doesn't bankrupt you, and you carry on taking your regular medication, then try things. Okay, try, if you notice your cough is worse when you eat something, exclude it. But if it's, chocolate and you love chocolate, then, don't exclude it. Don't do everything at once, because you'll never know what works. And that's, as logical advice as I can give.
And I think link that to anybody who, like Andy, was feeling lonely and isolated. I didn't talk to another IPF patient for my first 6 years. And it was a really strange period of time. We now have lots of support groups in many countries. Certainly in the UK, we've got 70 going on 80 support groups around the country. There are Facebook groups you can join for advice. Get out there and seek advice if any of you are feeling alone. Come to us at EUPFF. Come to your national organisations like Action for Pulmonary Fibrosis, which has a helpline in the UK. Even if you're not from the UK, you can call APF if you speak English. It'll be fine. You'll be very welcome as well. Okay, Phil, I'd like to thank you very much indeed. Your children in the background are screaming out for attention. And we're really grateful to you for coming at this very, unsociable hour to talk to us. It's been great as ever. Thanks for your support. Andy and John, thank you very much for bringing the patient perspective in. I think it's been a great discussion, and it will be interesting from both of you, actually. Maybe we ought to have a joint, now that you're brothers together, a joint sort of article on the experience. I think we need to bring more patient voices out on the cough experience into the public domain as well. But thanks, everybody. And in the background, Alba, thank you as ever for everything you do, and for making these webinars possible. So thanks a lot.
Steve, will we be answering some of the questions we haven't been answering in the chat or in the Q&A later?
I think we've covered almost all of them, and we will look at them and we'll get in touch with anybody who has it, but who has put one in that we haven't answered. There was a couple of questions about natural, green tea and other solutions, but I think they all fit into the Phil's category of try them, and if they work, use them, and if they don't work, swap to something else. It's self-management.
Don't stop the drugs that were prescribed.
Don't stop the drugs that were prescribed.
Yeah,
you're right.
Okay, great. Well, thank you all very much. Don't break the bank either. And thank you all very much. Thanks to the over 50 people who have been with us tonight, and to the others that watch this online later. It was great, and we'll be coming back to you soon with the timing of our next webinar in the series. So thanks very much indeed. Have a nice evening, everybody. Bye-bye.
Thank you. Bye-bye.